Hi, my name is Alikhani. I am Dean and Professor at CTOR Academy, and I'd like to welcome you to another session of CTOR channel. As part of the Back to the Clinic, I want to share with you an interesting case. A patient was an adult male that received orthodontics treatment in another clinic, and unfortunately, based on severity of his class 3 condition, orthodontist told the patient that he needs orthognathic surgery, and the patient refused to have orthognathic surgery. Orthodontists tried to achieve the best leveling and aligning in upper and lower arch, which unfortunately patient was not satisfied with. Therefore, the patient came to the CTOR Academy for possibility of non-surgical approach for correction of his underlying skeletal problems. When we examine intraorally this patient, we noticed that the patient has class 3 molar and canine, and it could go to the edge-to-edge relationship with the front teeth touching each other. However, especially in the right side, the back teeth would not touch. In addition, patient had constricted of upper jaw and lower teeth was lingually inclined. When we look at the panorex of this patient, it's noticed a remodeling of the condyle, but not very significant. However, due to the previous orthodontics treatment, he had a slight blunting of the roots that demonstrate patient is prone to root resorption if we are not very careful. When we're looking at the cephalometric profile of this patient, it confirmed that the patient has underlying skeletal class 3 hyperdivergency with an increase in the lower facial height. How we can treat this patient? Is leveling and aligning the only thing that we can provide for this patient, and patient doesn't have any other choice? We decided to expose patients to the orthopedic treatment, even though the patient is an adult, and many believes that orthopedic treatment cannot be provided for the adult. Patient received expander and face mask to stimulate the displacement of the maxilla. In addition, patient received periosteal stimulation to activate the cortical drifting. Remember, maxilla has two movements, displacement and cortical drifting, and both can be stimulated in the adult, especially cortical drifting should be one of our targets. After that, we progressed with the sectional mechanics, anterior V-band, stimulate further alveolar bone cortical drifting, especially in the anterior part of the maxilla, and using of vertical elastics to finish the occlusion at the end. Let's see what was the outcome of this treatment. Class 1 molar and canine reestablished, proper overjet and overbite reestablished for the patient. No further bone resorption or gingival resorption was observed in this patient. When we're looking at the panorex, we notice no further root resorption was observed in this patient, and cephalometric profile demonstrate that relationship between the maxilla and mandible improved significantly. What are the lessons that we learned from this case? The first lesson, if the patient is already prone to the root resorption, that should not prevent you from providing further treatment. You just need to be careful and apply lighter force. Second, if you are planning to apply orthopedic forces for this patient, you cannot apply high magnitude of the forces. The adult patients, the sutures are very interdigitated. They are not close, but they are very tight. And you need to wait until the osteoclast activated in these sutures. Therefore, you need to apply light forces. What are light forces? It means that you activate your expander at least every 3 days, once. In that case, gradually the bone density in the suture will decrease and you will be able to displace the maxilla both transversely and sagittally. Another lesson that we learned from this patient is that periosteal stimulation, that is activating the osteoclast beyond the response to the static forces, can be very useful in this patient. I encourage the readers to review the cortical drifting article that recently has been published so they get familiar with the biological principle of cortical drifting. Another lesson that we learned in this case is that camouflage treatment in this patient is not necessary, and I really want the orthodontist to think twice before thinking about camouflage treatment. You don't need to correct the class 3 patients by changing the inclination of the upper and lower anterior teeth, as you can see from the cephalometric result of this patient. You can establish a proper inclination without need for extracting a premolars in the lower. I hope you find this session of CTOR channel interesting. If you have not subscribed to our channel, please go ahead and subscribe, and please don't forget to press the like button. Thank you.